Let's get, we get settled. I told them in 2 minutes. Really good.
I just heard you say with the
lifestyle. I don't like where do you want to go?
definitely the office. And that's what I just got flashed. Going down.
The light, the screen is black. There's a cord back there.
It was probably black because I'm standing in front of the camera. That's why I just turned it off. So it's probably me moving. Or it's our internet. All of you online, I'm getting ready to hit the record button.
Can you all hear us? Can I get a thumbs up?
Only got one person. Amy, can you hear us? Okay.
Yeah.
And then I was wondering, is it?
Word button.
There's an AI operator there. Are we allowed to have AI note takers in? Okay.
No, we're supposed to not have AI.
Yeah.
We're supposed to kick them off the meeting.
Yeah.
Where's the AI?
It's read AI meeting is an R.
No, in here, Callie. The read AI meeting notice.
All right,
The
Mike.
blue, it's a blue AI. Right, I heard it.
This one.
No.
Oh.
It's a person, it looks like a person. It says read AI meeting notice.
It's little R.
Oh, my goodness.
Oh, between Sue and Debbie.
Is it on the?
It took me a while to see it.
I don't know.
I got it.
Oh.
Yeah, that's the first time I've seen that too.
Yeah, I'm looking for a person.
Okay. Took care of it.
Good, thank you.
I forgot I was on my phone.
Sorry for all the technical.
Now we're gonna get started. I want to welcome everybody to the meeting. It's our quarterly overdose prevention policy group meeting. I want to make a motion. I asked somebody to make a motion, to begin the meeting.
I move to begin the meeting.
I second.
All right, no objections? All right. Review of the previous minutes. I don't know when they went out. I can't honestly.
I think they came out with the agenda today.
Does anybody have any updates or anybody have any additions or deletions from the minutes? If not, I'll take a motion to accept the minutes. Or if people need a little bit of time, that's fine.
I move to accept the minutes.
Second.
All in favor? All right. We have today's agenda, which begins with a commissioner update. I think Commissioner Guerin was on.
Yes.
Yeah, good afternoon, everybody. I don't have anything for right now. Thank you.
All right.
Thank you.
And is Avery on? We have Avery.
Yes, I'm here. Thank you so much. A couple updates from Maryland's Office of Overdose Response, primarily around funding. So first off, our competitive grant process was open for the month of February, and we closed that application window on February 28th, so last Friday. We received 168 applications, which is up from 120 last year. So very excited that word's getting out about the opportunity. Also means the process will be really competitive to get funding, which it always is. But Just a note to folks for that. So next steps for us is going to be reviewing those applications to make sure all the documents we need are there, and then assembling our review committee. So it will be a couple weeks before awards come out, but I will certainly let folks here know once those decisions have been made. Additionally, the block grant funding NOFA either should already be out or will be out in the coming days for fiscal year 2026. The process is similar to years prior, so no real big updates there. And then also wanted to announce to folks that yesterday, the Opioid Restitution Fund State Discretionary Awards were announced. I can drop the link in the chat to the awarded projects for that. There were 28 applications that were awarded to the tune of $12.4 million. Some of those projects are 2-year projects instead of 1 year. Some are only 1 year. It kind of varies. But we have a summary of those projects that I will give you guys. And with that announcement, our new strategic plan for our office was also released. So I will also drop the link to that in the chat so folks can review those things. That is all that I have, but happy to take any questions if anybody has any.
Any questions for Avery on the board funding? Okay. And the next thing on the agenda, wait a minute.
That's her dropping in the
She
link.
dropped it. And I'm trying to pay attention to 3 things here. Presentation from Maryland Treatment Center, so we need to pull up,
Here we go.
the up arrow down at the bottom where you were.
This one?
Over.
Oh, yeah, there it is. Everything's different.
And I'd like to take this opportunity to introduce Megan Westwood with Maryland Treatment Centers. She was supposed to have a partner in crime, but her partner in crime is ill. So she's gonna solo this one.
Do you want me to come up, Kathy, and drive the PowerPoint?
Yeah, that would be amazing. No techno is me.
Well, you got us this far. I
Well,
try not to mess it up.
Put it back up. You'll have to present it again, because it was presenting, not in a slideshow.
Oh,
So,
okay.
It was what?
not presenting in a
Hold on.
slideshow, it's presenting with all the slides on the side.
Can you see that?
Yeah.
We have it.
And this was attached to the agenda, the invite. So if you're line virtually, you can pull this up to see it in a larger format, I believe. And we have a lock screen again. There we go.
Oh, I don't know why it's like that, but,
We have it.
oh, okay, it looks different here. Okay. All right, well, good afternoon. Thanks for having me. I'm Megan Westwood. I'm the Chief of Programs for Maryland Treatment Centers. And they asked if we could come do a little presentation on the programs that we offer at the Buttercup Road location, Mountain Manor, Sykesville, the Shoemaker, and the triage beds. We, just as background, Maryland Treatment Centers, also known as Mountain Manor, has been partnering with Carroll County now for 16 years.
Yeah.
Since 2009, right?
Yeah.
Since they decided that they would put the Shoemaker out to open solicitation. We were very fortunate to win that open solicitation and have maintained a really nice partnership ever since. And since then, we all know that there is, we've been trying to keep up with what is happening in the community and make sure services are matching the need. And so there's been some iterations of what that has looked like. And part of what the county did, as you all are well aware, is they have the Mountain Manor, what we call the Sykesville location now, which has also taken some iterations over the years, starting with sort of residential support services, is what they called it. Then I can't remember how many years ago, but they transitioned that to long-term residential care, put out a new RFP. Maryland Treatment Centers, again, was lucky enough to win that in an open competitive solicitation. We had 2 facilities, the Shoemaker Center up on the Springfield campus, the long-term residential at Mountain Manor, Sykesville, when we had to move out of the Springfield campus, we co-located those facilities, really nice sort of continuity of care. So I can talk about a little bit what those services. In addition, with the most recent past two solicitations, the county asked that whoever operated this also would operate the county's triage beds so that there would be rapid access for stabilization, evaluation, and assessment for people who are in crisis to hopefully keep people out of emergency rooms and more quickly get them into care. So that's about I think it's 6 beds are dedicated to the triage beds. It made sense because in the detox or 3.7 WM, we'll talk about that a little bit, level of care, we do have a full nursing team, a medical team, round the clock coverage. So it was a really good place to marry those services and create a pathway for folks who may just be bouncing in the emergency department. So the police are pulling them up and dropping them at the emergency department, that they can come to us. We can do rapid stabilization. It's been a really nice model. And I can talk through some of the data that we have on that sort of showed how effective it's. I probably am getting all over. So we talked a little bit about it. We are accredited by the Joint Commission. We're licensed by the Behavioral Health Administration to provide inpatient medical detox for symptoms of withdrawal, which is the American Society of Addiction Medicine 3.7 and 3.7 WM for withdrawal management. The program is, the operations of the program are fully funded through third-party reimbursements. So primarily Medicaid, but we do take commercial, we are paneled with all commercial insurances. So the arrangement has been that we use the facility that was created to support people, the residents of Carroll County, but that we got licensed and accredited, and we're a Medicaid provider, so that we pay for our own services there. Physically, it is fully funded by the third-party reimbursements. And the triage beds, they can talk about funding a little bit with you about how that works. Those are per diem rates that we are reimbursed for, but often they convert to a Medicaid bed so that there's very little cost coming through the county. I think it's mostly state funds anyway.
It's
State and
federal funds.
federal, well,
For the triage beds,
Right, so-
and anything that is not opioid related or stimulant related is funded by a little tiny piece of money that we get from BHA, because from inception we have said we weren't doing this for just opioid. So we have a little pocket of money, which is like $35,000.
and not been highly utilized.
No, mental health or
Yeah.
straight alcoholic or something like that, but
Yeah. So
traditionally it's been
the
used as intended.
I'm fortunate enough to do work across several jurisdictions, and I have to tell you, this is a great model where people are struggling with what to do with folks who are in this crisis moment, either, really feeling at ends, don't know. And we have a moment in time where they may have some level of motivation, and it might be 10 o'clock on a Saturday night, and most places don't have any place to send them. So this has been a really nice model to be able to adjust those.
Are the 60 beds all in Carroll County?
They're all in Carroll County.
So
Yeah.
all
All in one facility at the Buttercup Lane.
There's 60 beds.
There's 60 beds in there, yeah.
Is that what it was when we started?
It was 54,
Originally 48, it went up to
48,
54.
yeah, and now
And then we worked to make it 60.
we did some reconfiguring
And
stuff.
then 6 additional triage beds for the,
That, the 60 includes the 6 triage beds. So 54 treatment beds, 6
And
triage beds,
are juveniles included in this,
No.
or is this just
18 and
adults?
older.
Okay.
and Shoemaker is gone. That building is separate, is all gone.
The services for Shoemaker exist within Buttercup.
But we just call it all one thing now. Do we call it?
We do call it Shoemaker and
So
and
maybe I'm
Mountain
just
Manor
trying to,
Sykesville.
I've been following this since the beginning of time, so trying to understand.
Yeah.
So Shoemaker physically is not a location anymore. It's a
Correct.
hospital. Everything is 60 beds here.
Correct.
So what's the difference in who goes to the Shoemaker program and who goes to the,
So-
what do you call it, RSS, or what do you call it?
It's long-term residential Mountain Manor Sykesville.
What do you call it?
We call it Mountain Manor Sykesville,
MMS.
MMS.
Okay. So
It's based on clinical criteria. So when people come in and we do an evaluation, we determine whether they need withdrawal management, which would then mean we would admit them into the detox program, which is Shoemaker, right? Which is typically could be a week to 3 or 4 weeks. They have to, as we reevaluate sort of their clinical presentation and need. And then anyone who would like to and meets clinical criteria can stay to participate in the long-term program, which is Mount Manor Psych School.
So Shoemaker is the 6 beds, the detox?
It's correct. 12. 12. 6 triage beds. So whatever the mouth is on that, the rest of the long-term beds. Does that make sense?
But Shoemaker and residential, right? Don't you do 28-day, 30-day, whatever length of stay? Somebody doesn't want to stay long-term, or are you transferring everybody into long-term residential?
No, they might stay for a month just in Shoemaker, and if they decide they want to stay longer, then we can transfer them into the long-term program. So lengths of stay can vary from 3 weeks to 6 months.
And there's, so 12, 60 minus 12 is 48, so there are 48 long-term
Correct.
beds.
That's correct.
Okay.
That's correct.
Just trying to get straight.
6.
And-
No, I'm sorry, it's 42 long-term beds. I'm sorry. 6 triage, 12 detox. And now the state has allowed us to be a little bit flexible with the triage, with the detox beds and the residential beds, so that we can be a little more flexible in how we admit people. So if we're at 12 people in detox and somebody really needs detox, we can temporarily use one of those beds.
Sharon has a question.
No, my question is just around the utilization of the triage beds. How well utilized are they?
I'm sorry.
The triage beds, how well utilized are the triage beds?
Well, it seems to ebb and flow a little bit. I have some data coming up if you want to hold on a little bit, and I can show you what we've done in the last year. Typically, we are not at 6 people in the triage beds. Which also means that we
on a presentation, we can't see it. I don't know.
It's in the invite, Sharon.
Oh, okay, I'll look at it there. Thanks.
I'm not sharing the screen.
Oh, really?
I thought we were sharing the screen.
I think you have to do escape.
See, you shouldn't have trusted me with this, Kathy.
Oh, there we go. Okay, and then you just go
What do I do now?
to the little arrow up. Next to the smiley face. Teresa's coming to see
Okay,
Oh,
so
this
there we
arrow
go.
was- I see.
And then that, but it doesn't go to a full screen, so click there,
But then we'll at least be on.
share.
Yeah, let's see what this one is. Okay. Share. I am very sorry. No, it doesn't go, I can't click at the slideshow then.
So then. it
You
has
probably have to
be
go back to your tab at the top
This way.
and change it to slides.
You can't do it from here.
No, because you're presenting that tab.
I'm presenting the tab. Oh, I know what I need to do. I need to share this. Yes.
PP, there we go.
Where's Amy Lachelle?
Go to window, go to the top.
Yeah, go to the window.
In the middle. Down, no, go down.
In the middle beside current tab.
This one?
Wait, yeah, you had one.
That's what you get with a couple of social workers. That's what I did before.
But then you have to go here and do this. Watch out.
Oh, I
That's
see.
what you're presenting.
Can you see that now?
No.
Is it now being shared? I don't think so.
You have to go, if you click on it where it says window.
So go back.
Go back there.
That
Click
middle
down
one
where it says window, right there.
I see.
Oh, got it.
There you go.
You learn something new every day.
Yeah.
Got it now. Thank you.
Okay.
But I don't know if that is gonna work either, to tell you the truth. That's not working either.
You should be able to go back to that window now and just function from that window.
From here?
Go back to the PowerPoint like you had gone back to, yep. And you should be able to go from there.
Okay.
And just make sure they're seeing.
Can you see
I
that?
can see it. So.
Oh, you can see it on there. Okay. All right. Back in business. So back to your question, we'll talk in a minute about what the triage beds utilization has looked like. Because I think there's some interesting, I was actually pretty pleased with some of the information that when I was digging into this about how those triage beds have been working. So we talked a little bit about how the program is licensed. We have the 12 medically monitored withdrawal management, formerly called detox programs. I'm sure they'll use a new name soon. And then the medium intensity and high intensity residential treatment, which is 3.3 and 3.5. So that is sort of our framework for identifying critical criteria for those programs and what we use to get authorizations through the ASL to get reimbursed. So we talked a little bit about the triage crisis beds, the 6 beds that were intended for rapid stabilization. Sue talked about the funding. They have to have an opiate or stimulant use disorder. They broadened that a bit to be able to treat others that might be in crisis so that we didn't exclude other funds. And here are the funds that cover the
Yeah, this just shows
Triage
the
crisis.
reduction from, even in just the last couple of years. So we originally had 750,000 for these triage beds in FY '24, fiscal year '24. And then we reduced to 107.9 for FY '25 and '26. We've been level funded for FY '26.
One of the things as we got into doing this several years back is we very clearly were identifying, the county identified, we identified as a provider that what we're trying to accomplish is to stabilize, but hopefully engage them in sort of some plan beyond the night, the 4 nights or whatever they might spend with us getting stabilized. That was critical to this because we don't want to just keep bouncing people around. So as a result, what happened, a lot of folks opted to stay in treatment, which means we could convert them to a regular detox bed. We could use their Medicaid, we could get them Medicaid, or we'd start exploring community resources for them if they didn't want to do that, or Boggs couldn't make them, obviously. What we found is almost all of them stayed and went into care. And I'll give you, which is great news. So it means we often didn't even use the 4 days of the triage funding because on day 2, they said, no, I really want to be a detox. And we could transition them over and really stretch dollars that way, which was really a nice development to see that they wanted to stay in care. And we'll talk a little bit more about
One
that.
other thing I want to mention on this slide is one of the other significant changes that happened, and you'll have to remind me which year, because it was after I left, is that the federal government and the state came back, the state got their fingers snapped and said, no, this is 4 days.
Yes.
We used to have it for 10 days,
Right.
and the LBHA had the option to grant another 10 days if it took you that long to find a bed or find a placement. Because we do know there are times when it's very difficult
Very
to find that special program that somebody needs, when they come in with multiple issues going on. So that was a change. I want to say
22, 23, somewhere around there.
the state
Yeah.
came back and
Yeah.
said that people can only stay in these beds for 4 days for crisis. They call them crisis beds. I don't call that a crisis bed. If it was a true crisis bed, you would be getting paid from the state,
Right.
$300 a day for the crisis bed. That is not how this program was set up. It was set up kind of like a stopgap. And the funding, I don't even remember what you get, 215?
No, it's changed.
No, it's changed. It went up this year.
No, it's much
It's
higher.
much higher.
it's
It's
like five.
more consistent with the detox right now.
Yeah, it is.
Yeah, it's like
That's very
5
good
something.
then, because
It was
that's
good.
one of
It was
the
good.
things that-
But we've also been able to reduce the number of days in triage significantly. I think the average is like 2 days in the triage beds before they.
Where they are.
What?
Being right there on the-
Because they're right there, right? To them, it feels seamless.
Can I, so I feel like someone can go there, I feel like I've sent people there that don't have insurance, and then you can get them.
Correct.
just, you know, like,
Correct,
Yeah.
correct.
Yeah, it's a perfect.
Yeah,
Yeah.
so
They
there
don't need
shouldn't be any
insurance.
barrier.
Yeah.
There
Yeah,
should
they
not
don't
be.
need insurance for the triage, but
Yep,
by the
it's all
time
being
they
covered
get
by the grant.
stabilized and ready. they
Yeah,
can-
and even if they don't have insurance, if they say they get there, they're uninsured, they're homeless, they have very little resources, we can get them uninsured eligibility funds to continue in treatment as usual, so into detox, and then we work with getting them their
And
regular
those
Medicaid.
uninsured eligibilities are approved by Susan.
So,
Here.
None of that comes back to county dollars. We're able to do all of that through Medicaid and been pretty successful with it.
Yeah.
At revenue collection. Any other questions?
Who uses the triage beds? How do you get people there?
Well, I have some numbers on that. They come from the Carroll County Hospital. We've had the Sheriff's Department come.
The only reason I'm
Um,
asking,
Yeah.
I've talked to some of the law enforcement, don't seem aware of it and doesn't seem that it's convenient. And I just want to know, how do we get the most message out? This is where you take people, or can, and it's available.
It's interesting because law enforcement was one of the first populations we opened it up to after the hospital.
Yeah, and they do bring people. They'll just bring them to our door.
And the reason I'm asking is because we keep saying we have this need. And I've been involved with this since it was built. And then we purposely put the beds there for triage. I want to see if they're being used because we keep saying we have this need for triage beds. And I want to know if we're using the ones that we already have and paid for and
Very specifically for substance use disorder and mostly opioid.
Right.
methamphetamine, yeah.
Right. That's what.
The criteria is very specific.
And I think Megan can talk to the numbers later on, because I think there's been a trend in, increasing the
There
number
has
of people
been.
admitted. to
I would say the
triage.
first couple of years, it was not highly utilized. And over, particularly the last year or so, we've seen a spike in the number of people, and whether the word's getting out or whatever that may be, we are seeing more utilization of those beds.
I think
which
a
is
lot has to do with the peer, peer
Yes.
rehabilitation, especially at the hospital. But I think some of maybe some officers not knowing could just be because a lot of officers know, but I guess everybody, maybe you change shifts, maybe there's new ones that go from day to night. I mean, I don't know. I'm speaking for the sheriff's department. There's a few that would have called me that have.
Yeah.
And I'm asking because it is, I think this is a seamless way to do it.
Oh, yeah.
And to have them go there, and that's where we, for whatever reason, some people say it's not convenient because it's not centrally located.
Yes.
That's where we decided to put it 20 years ago. And it seems like we want to make sure we're utilizing it because it is a seamless, good way to go in and get treatment and be right there.
It is, and that piece of it is working very nicely, and I think is a really nice model that I'd love to see reproduced. Yeah, it's not a drop-in center in downtown Westminster, but they also can stay, right? We have the whole continuum of services, and I'll get ahead of myself a little bit here, but one of the things that was super interesting to me as I was putting this together is looking at, of all the people who came into the triage beds, what happened from there? Did they leave? All but one opted in 2024, all but one opted to stay and go into treatment. Now, some of them maybe after a week were like, I'm good, I'm gonna go. But the average length of stay in care, which means the uninterrupted care, they went to detox, they went to long-term residential, they may have gone to outpatient, was 68 days. Now, if you're not in necessarily the SUD world, that is a remarkable statistic, right? I was a little blown away by how many of these folks who came in on a whim in the middle of crisis, no luggage, right? They just show up, and 68 days later, they're still participating in treatment. That is remarkable. And I think really says we're onto something. And hopefully we can
Well, it's
increase.
the combination of the relationship, because we have peers here that can help with certain things. You have peers down there that can help with certain things. Tim has a network of people that, can connect people to these services.
But it doesn't feel like they're getting passed from service to service,
Right.
right? They come in, they get detox, then they, basically it doesn't really matter to them, right? They no longer meet criteria for medical detox, but they meet criteria for long-term. They're now in long-term.
They only tell
They
their
might
story
move ahead.
once.
They only
And
tell
then
their
one
story
of
once,
the
right?
Issues that we've
That's right.
constantly been trying to deal with is that people will go have an assessment, and if that level of care is not available at that facility, so then they get shipped to another facility, and then they have to tell that story all over again, which is re-traumatizing.
And the new counselor, the new doctor, they
Yes.
stay with the same doctor and the same team. And they don't know necessarily that you're now an MMS patient, you're now a Shoemaker patient. This is very seamless. 68 days is remarkable. I don't know if you saw that. When I was looking at this, I did it twice, by the way, because I was like, wow, that's pretty amazing that that's our average length of stay
If
with
someone's
this
in the ER and
population.
they need to come down there, how do they get there?
There's a.
How did they get down there if they're in the ER?
I think there's a medical Uber that takes them.
Yeah, I think they transport them
And
to
they,
us.
or the Uber.
Sure. Yeah,
Yeah.
yeah,
And I know Mobile Crisis has also
Yep.
taken
Yep.
people down.
police, sheriff, yep.
Transportation has always been our biggest.
We do have transportation down there too, limited, but if we're able, we'll go get them. I think we've kind of covered this. Do you want me to move along? I don't know how much time you want me to go on and on up here, but here are the levels of care. So we've talked about triage, which is not a treatment level of care. This is a model that was developed here in Carroll County to rapidly, again, stabilize and evaluate. And then we can step folks down from higher intensity of care, lower intensity of care, based on their symptoms, based on their acuity. It's not always seamless. Sometimes we have to bump them up, back up again if they were to have a relapse or they were to be struggling and we need to restabilize. We can move them up and down these levels of care depending on how their need and presentation is in their individualized treatment plan. Also, really nice that that doesn't mean going to another program or another provider somewhere else where they're starting over. Right? We just increase their dose of care. Anybody have questions about that? I'm in sort of technical speak here. Okay, so this is, we broke these statistics down. This is 2024. We looked at 2024. This is specifically for Mountain Manor Sykesville for those 42 long-term beds. Now, long-term can mean I think the average length of stay there is 4 to 6 months. 29 admissions were referred by the Carroll County Detention Center. That's new and very exciting. And one of the reasons we have a partnership with the Carroll County Detention Center. We have a peer and a counselor in there to help with planning for release. And we didn't used to get anybody from Carroll County Detention Center right into residential care, which is a perfect step down for these folks who maybe have an opiate use disorder or another substance use disorder. And even though they've been incarcerated, they may not need withdrawal management or detox because they've been there for a while. We can step them right into residential, bed to bed. They never hit the streets.
Are there, of that 29 admissions, are they people that have been released from this?
Yeah,
What about the?
You take
ones
some on
that-
detainer.
we do take people on detainer.
Yeah,
I think that the 29 is directly from, they've been released.
Oh, they've been released.
They've been released, yeah.
Is there a spot that shows the ones that came in custody of? I'm just curious,
I don't know, hold on, if Lauren put it in.
No, I don't think that's in there.
No, I don't think so, but we do have people on retainer quite often.
You guys being in there, obviously Toronto is great too, but I've been over there and literally meet with someone and walk out and Deanne's right there, and she's like, oh, I can just do it right now. She'll come right in.
Yeah.
Do the.
Yeah, because they're there for the
Yeah.
medically,
Right.
medication.
That's how I know it's a
assisted
lot.
Yeah.
treatment.
So that's been hugely, that's a whole different presentation, but that's been a really, really great partnership.
Yeah.
Because we know how critical that period is when people are leaving incarceration if they are not immediately linked to
Well,
care.
and even having the in custody part of it, because
Mhm. Not many people will do that, but we do that. We've always done that. Yeah.
We did that too when we were in Shoemaker.
So yeah, that's because they did it at Shoemaker, so we adopted that practice. 11 admissions were from Carroll County Health Department, 3 admissions by Carroll County Drug Court, and 88 of the 2024 admissions were Carroll County residents, which is about 58%. So yeah.
Do you have the breakdown of the health department's admissions? Do those include like our reentry staff at the detention center? Or those just our like community?
I don't know. If Lauren's listening, maybe she will chime in, but I don't know, actually.
Hi guys, can you hear me?
Hi, Lauren.
Oh, from her sick
Sorry,
bed.
I can't come off on video, but those were a combination of a health department admissions off the street and in the detention center as well.
Hey, Lauren, what about directly from the peers at the hospital from the?
Is this for MMS? I'm sorry, I just logged on. I'm trying to catch up.
This is long-term.
Not triage.
Okay.
And not, so there's,
Yeah,
remember,
so
we've
these-
also got straight to detox, straight to triage, straight to. The
Yeah.
long-terms tend to be more medically stable, so usually aren't coming from the
Yeah.
emergency department.
Yeah.
Yeah,
They
these
go in-
wouldn't be from the emergency department.
Yeah.
That makes total sense.
So by contract, they've asked us to use the facility for at least 30% of Carroll County residents. You can see we far exceed that. It runs more, and this is not including the triage beds, which are 100%
Right.
Carroll County. 58%. Now, just to make, again, this fully funds the operation of the program so that we can take with Medicaid expansion and some other regulatory changes in the state, we were allowed to move past people can have choice where they can get treatment, so they can move without
Yeah,
around the
there's
state.
limited county dollars that go into it. It's really just maintenance of the building.
It's really just, so they just maintain.
And
the
in
building.
order for you to collect from Medicaid and other insurances, we cannot limit.
We cannot say
admissions
we will not
to
admit
Carroll
anyone
County
else.
only, or else it would have to be funded by the county.
Yeah.
100%. They will
Right,
not.
you
If
can't
you
do that.
enter into a contract with an insurance company or an MCO or with the ACO, the requirement is that you have to accept throughout the state.
Correct.
The fact that it's located in Carroll County puts it, and traditionally when we ran it, we were in the 40%, usually.
Yeah.
As a statewide facility
Right.
and a grant.
And even
fund,
under the
so.
grant fund, it was limited to certain counties.
Yeah, so all the, just the maintenance, I mean, the building's owned by the county, the maintenance on the building.
Yeah.
So there's no other contract for the Carroll County other than you get the building, then you bill for all the, you bill insurance.
Right.
And then they pay your utilities, you got it.
Yes, we pay the
So
utility,
the only
the
thing that
phone,
Carroll
all
does
that.
is get you the
The
facility.
space.
Yeah, the
And
only
we
other
do the
contract,
cleaning and that.
yeah,
kind
the
of
only
thing.
other
So we-
contracts that exist is a contract with the county for the LVHA to monitor what's going on down there.
So in
No,
addition
yeah.
to what we do for the state, we monitor the agreement with the county, with them,
Right.
and Mountain Manor. There are extra things.
We're like
we
the
do.
go-between, yeah.
Where we learned,
And then-
when she first came to work here, I was like, yes, we can monitor that because that's part of this agreement, not the state's agreement. So it's a nice blend of.
It's a really nice band. The building maintenance, let's just be clear, like, big maintenance and upkeep. But day-to-day upkeep is our responsibility, the cleaning of the facility, wear and tear on the facility, those things we take care of.
Furniture replacement.
Furniture
other things, some of the
replacement,
kitchen
all the office
items.
furniture, all that.
That's all on there.
If it needs a new roof or something structurally, then we can.
Yes.
And we're also using the county's opioid restitution funds to pay the contract for the counselor and the peer in the jail is funded with. the
Correct.
county's opioid restitution.
So,
That's right.
and because we're so closely linked, it's so embedded in the continuum of services.
Oh, yes,
in-
yes. It's very seamless.
It's very seamless. So we do have 58%, Carroll County in my Montgomery County programs. I bet we do not have 58% Montgomery County residents in there. In fact, I'm sure we don't. So, we really feel good about that service that we're providing to your residents, that this is making a difference. So now we're talking about the detox program and withdrawal maintenance, 8 admissions from Carroll County Hospital, 4 from Carroll County Health Department, 5 were from the Carroll County Detention Center, 2 from drug court, and 78 were admissions were Carroll County residents, which is 55%. That's right into the detox program. Again, far exceeding what the contractual requirement is. But gives you a flavor. And then the rest of them may have come from other counties.
The hospital's not, still not.
Yeah, top one,
Oh, okay.
top one.
And so the other people just come, people just
Tim,
walk in,
those-
They call and scream and
That must be
find
Sharon
them.
somebody tells them about it, somebody just tells.
Yes, people
Sharon
know
or-
Shoemaker.
Or Lauren. I don't know who was.
Somebody tried to say something.
Lauren, was that you?
The peers probably are
Peers.
referring to them.
Yes.
Yeah, so I was just gonna say that to Tim, that those are the peer referrals though.
Those are the pure referrals.
So when they come into the hospital, if it's alcohol, opioid related, I mean, the peers are immediately on it, start that process of talking to them through the. And the reason it looks so low, I mean, not to say it looks low, but is because sometimes they go other places.
Right.
But they are sending people places.
Yeah. We get them at all our facilities, which is great.
Yeah, they could go to Mount Mary.
Yeah, the Ava Road, wherever, and we do.
Yeah.
And
Real quick question around that. Is some of the limitations maybe from the hospital, do you have limitations for people who have medically complex needs, oxygen or other things?
yes, there are, I wouldn't say there are blanket things that we will not accept. Fortunately, the building is set up so people with ambulatory challenges, it's not a problem. We have plenty of people with ambulatory challenges. We're are pretty proud of the fact that we probably treat more medically acute than many programs will. We have it all evaluated by our medical team, and we just want to make sure it's a safe placement. If there's something that they need that we cannot provide safely in this setting, then that was the only time. We very rarely turn people down for medical acuity, but it happens.
Well, I know.
We don't hang IVs, for example.
Right, it also depends on your medical staff's ability to provide care too.
Ex-
right?
that's exactly
So,
what it is.
You know, if you don't have the right nursing staff to be able to provide
Wound care.
wound care or whatever that's necessary, then it wouldn't be an appropriate referral.
But we see, you know, this is because it is a medically monitored program and it's a medical service. We are often the first diagnosers of diabetes, hypertension, pregnancy, many things, right? That we do treat on site. Can't do it all, right? We have our very, our nurse practitioner there is amazing. She's been there forever. She does a lot of work. We have psychiatrists on the team there. We have mental health therapists. We have addictions counselors, but we're not hanging IVs. We're not a full-blown hospital.
But you've taken people who are on dialysis.
Oh,
and
we
they
have.
Need to go to do their
We
dialysis
have.
and they come back and.
Yeah, we have.
Of course, you have
Which
to
is
factor that
challenging.
into how you,
Yeah.
Get the treatment hours in.
Yeah. Right. And we're also required to provide so much services. And if they're not in the building, we can't really do that.
So basically, when she had the ASAM levels of care up there and it talked about acute detox and then the longer terms and moderate, it basically saying how many hours of treatment you have to do a week with those people. So people who are in detox, it's still
37,
36 or 37 hours a week.
37.
But once you move out of the detox and intensive
20.
medical, and then it goes down to the
Right.
lowest level, I think you do is 5 hours of treatment.
In 3-1, yeah.
And then I can go out and work during the day, so you do the services at night. So it's 24 hours. And it's
24
24
hours. I'm sorry, what?
Can they go out and work?
Only if they were in 3-1. We don't have many 3-1s. We tend to refer them out because it's a little tricky
Yeah.
to blend those treatment programs, right? When I have people in detox at one building and somebody else is coming in and out of the building to keep it secure and make sure it's a safe place. But we do take them out. It is really important that as they work through care, I don't need to tell you, but that they connect with the community and make sure they start building a network and make sure they are connected to the resources in the community so they're not going out there feeling alone. But we do often step them down to a 3-1 regimen.
You guys do take people with wounds?
Hence, if they can self-care for it, if they can manage it, if they need a specialty wound care, we don't have that. That's been a big issue in recent years.
Yeah.
We've actually been sort of applying for certain grants to see if we can
and I
get some funding to up
hyperbaric
our
care
ability.
or anything
Yeah.
like that, not so much.
Not so much.
Right, you know.
And one more question, where do the people, you said 58% of the people, 100% of the triage beds are for Carroll County residents,
Right.
but you said you're serving about 58% of Carroll County residents. Where are you seeing the other patients coming from?
Probably plenty out of Baltimore City, Baltimore County, Frederick.
Frederick County, Baltimore County, and Baltimore City are, we've seen some in Washington, but those are predominantly where we're seeing them.
Yes.
So when it was grant funded, our area, our catchment area.
What was it,
Harford
Howard?
County, Carroll County, Howard County, Frederick County, and Baltimore County. right?
Baltimore County, right?
There's 5. We had 5 counties. Because when they called us, we had 4, and they called us and said, Harford County doesn't have a catchment area. What would happen if we put them in your catchment area? I was like, just make my waiting list longer.
Most of the counties in Maryland do not have their own detox facility, right? Most of them do not. So people do travel to other counties to get.
And there's not a lot of detox.
And there's not a lot. There's not a lot. Now, we're fortunate, we have 4. So I think that if somebody asked me once, well, what do you do if you really don't have a detox bed? We always have a detox bed somewhere.
Yeah.
And we will convict them. We'll take, assuming they're willing to go to one of our facilities, we have really made an effort to be same day, next day admission. So if we don't have a bed there, we do have a bed somewhere else. And we often refer back to the long-term program once they finish detox. Yeah.
Are you detoxing pregnant women?
Yes.
Okay.
Priority is a priority.
Yeah, they are.
I just want to make
It's a
sure.
priority for the state.
Yeah, yeah.
Definitely.
we absolutely do.
What is it? Now, how many detox beds do you have?
Well,
Okay. 12 just at Shoemaker.
correct.
Yeah.
Correct. But we always have the
Yeah.
system. So we've been running pretty steadily at 85-90%. It was a little tricky. We had some renovation periods going on, so the capacity shifted a little bit, but we're at full capacity now. We talked about that we have exceeded the requirement of 30% of the residents being the Carroll County residents at almost 60% if you include in the triage. And we've talked about the fact that how this is funded, that the bulk of the services there, with the exception of those federal dollars for the triage days, which are, we've condensed considerably because we're not using 4 triage days, we're using 2, and then transitioning into Medicaid dollars, is 100% funded through our ability to collect revenue.
And those bids we know are funded for FY 26, but we're unsure what's gonna happen 27, 28, 29. Because they have to apply every year for those dollars, the sewer money.
Yeah.
I included some information about, we have a pretty robust organizational performance improvement committee and data collection. That this is just a snapshot of some of the things we look at, but we look at critical incidents, we look at risk, we look at harm factors, we look at perception of cares, and I thought you might be interested in what are people saying. We're interested in what our clients say about us. So everybody gets the opportunity to fill out a survey. We just took some of them. I don't know that you need me to read all these. I think people have the slides, but we're pretty pleased with what they're saying about their treatment experience. Do you want me
Well,
to?
it's pretty clear that they're leaving with education. Sorry.
I just want to know if you did follow up after someone gets released and how long you thought tracking for.
Yeah, we're not really resourced to track everyone because we don't always know where they go. A lot of the folks that stay in Carroll County, this is a pretty tight community, and some of them stay with us in their aftercare program and our outpatient program. So we we will see them for 2 years sometimes.
That's only for you.
And that was this. Let me go down to this, to the
I
triage.
shouldn't know how you define success.
Well,
That's an individual based determination, right? So for some, it's maintaining a week of sobriety. For those that can't maintain sobriety.
Yeah.
You know?
But I will say, and one of the reasons that I mentioned that this 68-day average retention for people who are coming in really on a limb off the street, that is a big measure for us in my field about how retention and engagement are huge. Because to us, first of all, it's very hard for us to say we cure 100% of people. We do not. People don't get better that way. They don't get better in a straight line. But are they having less periods of illness? Are they having less periods of acute symptoms of disease? Are they having less periods of homelessness, less periods of incarceration? That's what we're interested in. And we know how that happens over time is longer engagement in treatment. So 68 days, I know it doesn't sound like forever, that's a pretty impressive number. And several of them, when I went through, I did line by line, all the triage. I looked at every client. I was shocked how many of them went from triage to detox to long-term residential to outpatient. And they were in care with us for over a year and a half, some of them, which is amazing. That's for this population, that's pretty amazing. And there was no gap in between.
So one of the things we struggled with when we operated long-term care and residential services was that when people leave residential, getting them to the next location and getting them engaged is the most critical thing.
That's a big deal.
Because when we would readmit people, we would say what went wrong.
They didn't
And
know.
we never got to their outpatient location because the appointment was 2 weeks off.
Yeah.
So this system being
Mhm.
continuous and being able to move through those levels of care and then allowing them to stay in their community for their outpatient is really a seamless, because you're looking for them if you look them up with yourself.
Correct.
You guys are out there. going,
And we've
"What
already
happened?
enrolled
Where
them.
are you?"
They've already done some virtual enrollment. They're already in. So when I talk about our performance measures and how we know we're doing well, is that we get people engaged and we keep them engaged and we retain them in care. These gaps, what we know statistically, nationally, about 70% of people who do a residential stay drop out of care the day they leave the bed. Our rates here, we are getting about 60% of them that we're referring from our program to outpatient. So we're really doing well on that. To me, we still got a long way around. There's 40% of them still out there somewhere that need help, and we know it's a better thing, but they think they got it, and hopefully they do. But that, to me, those are the measures we need to be looking at, because those are what we know are best prognosis.
Chief Ledwell has the hand.
Oh, I'm sorry.
I
can't see, so.
No.
Go ahead, Chief.
So did you say that this PowerPoint was attached to the invite? Because I didn't see it. I went and tried to find it. If
Is
not,
it, Sue?
It's down, just over on the side, down the bottom. I couldn't, it wouldn't open for me, but it's.
Susan's saying it's down on the side on the bottom of the
On the
invite,
right
but
side, the envelope says attachments, and it came today.
yeah, I.
Can you resend it?
I can make sure you get it.
They'll make sure it gets
Well,
sent
we'll
out
send
if you
it
can't
out.
find it.
And can you send it as an attachment because I can't open it?
Send it
Yeah,
as an
we'll send it as a follow-up.
All right, they heard you.
That's my technical skills.
I do want to reference the fact that you do follow-up for our triage beds, because you have. to
Oh,
pay
yeah.
for it.
Yes, we do.
So that's a mandate from the federal government that they have to do follow-up. Is it 30 days, 3 months, 9 months?
Something like that. I don't think it's 9 months.
I don't
Maybe
know.
90 days,
I
but
can't
something like
remember
that,
the
yeah.
days, but.
I tell you, one of the things that I can measure success by, because I will, there's two people that I know that I call that are people that I help get into treatment, and now they work there. That's pretty cool.
I love
Yeah.
that.
Yeah, and
I
to
love
walk
that.
through the jail and see someone that's in the jail getting people in treatment, it's,
I mean, we have really, I give the Brains in Carroll County a lot of credit for really revolutionizing some of the ways we've addressed this problem. I mean, you guys have been ahead of the curve here on this, but to have the peers, now that was a state mandate, right? That they
Right.
start doing MAT in the jail, but this partnership has been phenomenal. When you look at the statistics of the number of people they are starting on MAT in the jail and how they're connecting with care in a way they never were. I mean, what do we say? 28, 29 of them came into residential care right from the detention center. That's never happened before.
Right. That means they're not walking out and.
They
using
were
the
walking
same
out
day they release.
with maybe a piece of paper that said, don't forget you have an appointment next
Right.
week. We drive them from there into care. That's huge. 29, that's huge. So these are really innovative things that are happening here in conjunction with the triage beds, which you always worry, is this going to be just them bouncing in and bouncing in? But that hasn't been the case. I mean, we're really doing well.
are you also seeing any first responders bringing anybody in directly off the street?
Lauren, are you there? Can you answer that? I believe so.
Yeah, we have had a couple of those.
Couple.
Because I think our officers would probably utilize the resource more, but I don't think that they probably have a full understanding of what are the parameters, like who can you bring there?
Right.
And what the process.
We'd be happy to provide more information or meet with them, whatever you think would be helpful.
Yeah, I think, if you guys could do like an information session, either, we could divide it into 2 roll calls or in-service presentation. I think it'd be helpful.
I'll volunteer
That
Lauren
would be great.
McCarthy,
Yeah.
since she didn't show up today.
I'm sorry, guys.
So I can see.
Okay.
I'm sorry.
Oh,
I
yeah.
just wanted, I think somebody else has their hand up. Sharon?
No, I just wanted to ask what are the criteria for triage beds? And question is, the other thing is, how many people that come to the triage bed actually end up engaging in treatment versus not? You know what I mean?
I just missed that whole question. Sorry, I was playing with the computer.
Oh, that's okay. So first question is, what are the criteria for, if you could just share that, the criteria for the use of the crisis beds? And then I'm just curious to know how many people that are brought to crisis actually stay and engage in treatment. What percentage of the people who come?
Like 99%.
Okay, good.
We had all but one stay. There was a couple who maybe only stayed a couple days, but for the almost 100% of them stayed and went into treatment. The criteria is really an opioid use disorder, a stimulant use disorder, and it's really tied to their funding source. And obviously, if somebody comes in and they, are critically ill and need to go to the hospital, we're going to send them to the hospital. They have to, but we expect them to see some psychiatric acuity. We certainly expect to see, big impairment related to substance use disorder, and symptoms are often intertwined. So it's not a particularly exclusionary set of criteria. We want to
I can
help.
certainly send out the triage flyer again too with the application on it. I think I've sent it out before, but it was many, many months ago. So just to keep that on our forefront.
Yeah, and staff's turnover, and so we need to keep
I
getting
think
it
the
out
other
there.
thing to highlight with those crisis stabilization beds and the crisis triage beds, whatever we're calling them, and any other level of care there, is that the client has to be able to take care of themselves.
Right.
Right? They have to be able to shower themselves, feed themselves, and all of those things that go along with being in that level of care.
Right.
So,
Right.
it's not a skilled nursing care center per se. So,
But still pretty broad, right? You know, we
yeah,
still
for
pretty
medical
broad.
issue, right? but
Yeah.
Yeah, you're not gonna
But-
feed
but
somebody.
we're not,
or
you know,
toilet somebody.
That's right, and shower them and those kind of things. Clean
Is
IVs.
alcohol
And they-
is a stimulant?
Alcohol is not a stimulant, but they can come in under this small, on a triage bed under this small county funding. Yes, of course they
They
can.
can.
Yeah, yeah,
I think
absolutely.
the other thing to kind of note though with that is if 99% are going into treatment, we have to assume that 99% are either co-occurring or substance use only. They're not mental health only.
Correct.
So when we have an individual who's in the
Correct.
community that needs triage for mental health,
This is not the avenue
This
for
is
that,
not the best for them.
nor was it designed that way.
And the other piece, and I know we've talked about this in other meetings, as far as kind of barriers for first responders, whether it's law enforcement or it's fire EMS, to bring someone, like if we have a paramedic, because then that puts them offline during that transport period, right? So it's sometimes, and Chief Robinson and Chief Ledwell, if you want to speak to that, because I think that may be one of the barriers to getting people
Yeah.
unless they're closer, right? So
Right.
that was something that's come up multiple times about, you know, sometimes the why, and then also the intake form, right? I think there's got to be some additional, I think that is something that if it can be really streamlined for folks.
I know we have over time, but we can certainly revisit that, because we don't want to put up
Or I think
excessive
it's one
barriers
thing
to
to
it.
streamline for EMS who's already evaluated the person and law enforcement who's already engaged with them versus somebody being referred from
Right,
someplace
right,
else,
right.
you know what I
Yeah,
mean? Or the hospital who's already assessed and evaluated them. But or like Tim making a referral from the state's attorney's office, there's no assessment in the middle of all that. So that other form would work for that kind of.
Right. We'll just take
referral.
Tim's word for it, though.
Yeah, it's an easy form.
Yeah.
you know, to
Yeah.
fill out.
Yeah.
Yeah, if it occurs during hours where like, the case manager from lead QRT and a peer are working here, then obviously that could be easily coordinated through that team. It's more gonna be the off-hour ones where I think really need to reassure the officer as to what the process is, how long it'll take, what the criteria, is for getting somebody in there that would help. Because we'd be willing to transport as long as we have sufficient staffing for the squad. We still have to cover the city.
And I wouldn't think there'd be any reason for them to, it's not gonna be like an emergency department. They're not gonna have to sit in chairs for
Right.
hours. It would be, that part of it would be very
Right,
quick.
and drop them off.
It's pretty much drop them off if we've got a heads up that they're coming. And that has worked very well in the past. So we're happy to revisit that and re-educate and see what we can do. We really don't want to put unnecessary barriers up. That's why we got in this position in the first place, right? Anybody else have questions for me? Did you want to add anything, Kathy, Sue?
Tammy Blackscatter.
Oh, okay, great.
What if, so the people that are coming from the detention center,
Mhm.
do you have a number of how many of them are already started MAT?
I would think, I don't know, but I would think a significant number of these
I
are.
would think, now, do you also then have a number of how many of them are staying for the full length of it?
I haven't broken it down like that.
I'm just curious, just.
I'm sure we can do that. I think we can jump in and
Yeah.
Lauren's very smart. She can figure it out.
Yeah.
But I think probably, Lauren, if I'm correct, the reason we saw such a spike is because we are particularly working with that MAT
Yes,
population
that's what I.
in the
So-
detention center. So I assume most of them are.
Which
Is that,
good,
would that be
because
fair,
they're
Lauren?
directly there, yeah.
Would that be
Most
fair,
of
Lauren?
them are as to MMS, those numbers that we saw for
Right.
long-term residential. Um, Probably 85% of those are MAT.
Yeah,
And that is, directly sort of correlated with our MAT
That's
team.
right.
So our counselor works only with MAT clients there. And then the other 11, I think that they may have been on meds or, MAT or
They are
they're
not.
not.
They're coming in
But I
more
can get
crisis.
that.
situations. Yeah,
Deeper, I'd be curious to know methadone, Suboxone,
Yeah.
Suboxone. You know,
yes, and so without getting too technical in it, this is also, and again, you know very well, this is a significant performance measure for us that we look at. And I'll get a little nerdy for a minute here, but one of the things that we know nationally is that when people go into treatment for opiate use disorder particularly, the standard of care is medication-assisted treatment. Jury's not out on this anymore. That is the standard of care. About 18% in treatment as usual get inducted onto an MAT. We did a system-wide study about, it's probably 2 years old now, and then we doubled down a little bit, but we were getting about 45 to 50% of opiate use disordered clients inducted onto MAT, which we're thrilled about. It's double than the national average. We still got a long way to go, right? We'd love to see all of them. But that's, to your point, we do look at that pretty carefully because this is critical, right? We know this is the standard of care. We know it saves lives. We know people do better.
It also helps extend care.
It also keeps them in good care.
Tammy,
Yep. Hi, thank you for taking my hand. So I just wanted to clarify that before I've appreciated this program and we had to go through a triage process. I had to wait for someone to call me back and so on and so forth. But now that barrier's gone. Am I understanding correctly? We can just bring someone over who has, like a substance use disorder that we're thinking they do. As one of you said, I think maybe Kathy said, a lot of them do have co-occurring disorder, but you'll handle both of them since you have psychiatry on site now.
Yeah.
And then
I mean, we don't do, if they're actively suicidal, we don't have the ability to do one-on-one or holds, but
no,
yes,
I wouldn't think so, but that would
be a good
patient setting a higher level of care. I think we all get that. But I was just wondering, so the barrier is definitely much lower than it was even a couple years ago to get it did. And we can just bring folks by. Before, when I brought patients there was it was a pretty locked unit. So do we just bring the patient there, stand outside and do the buzzer, or how does that work now?
I'm going to let Lauren answer that. Yeah, please.
What was that?
Tammy, I think, we've moved the beds to MMS Sykesville, so it's not the locked facility anymore. So that should be helpful. But in terms of triage, we'll obviously need some information to make sure that, there aren't medical issues that have to be managed at a hospital level of care. But I think over the last couple of years, we've decreased those barriers. So if you have any issues or problems, please feel free to reach out to me directly. The other day, I got a call from a peer in the hospital in the middle of the night, and we worked it out. So we definitely want you guys to be able to utilize these for sure.
Yeah, we do need a heads up though, just to make sure we don't want people in crisis to be bounced around and come out and it doesn't work out. So it's probably better if we have a quick conversation and see what's going on.
So the other thing I want to point out, just because you just mentioned it, and Tammy mentioned standing outside of a locked facility, when the state went to fee for service for all substance abuse programs, was at the same time they went to accreditation for all programs, meaning that we no longer had HOMAR regulations that guided everything we did. We had accreditation.
Right.
That can be CARF, that can be Joint Commission, that can be the national something. But the issue was that the unit that we were on at Springfield on the medical surgical floor was not, would not meet criteria for accreditation. They didn't have anti-ligature doors. There was a lot of issues. Originally, the secretary at the time said that they could move us, or they could make adjustments to that floor for us. That turned into a $3 million project. So they moved us to an empty ward on Springfield, which then meant that 2 of the wards were occupied by mental health patients who were in locked units. And because it was a locked building, they were in a locked unit. So it caused a lot of problems, and it also decreased the amount of beds we had. So
it decreased the amount of beds, and honestly decreased the demand, because at the same time, patients could go everywhere, and they could go somewhere where they weren't locked in, or they go to Shoemaker, which was a little bit grim on the grounds of the psychiatric program. So this is much better.
Worked with the county to talk about relocating those so that all of the beds could be in one place. We had a contract with Mountain Mountain to do the Shoemaker. They had a contract for the long-term beds, and we just merged it into one contract, and we're all one big happy little contract now. We work together.
And really, I think a real model of how things could be done. I really do, that this seamless, that we're not taking them from detox and shipping them off to somewhere else for longer term resident. There's just less gaps.
Less chance of losing.
Less chance of losing them. So,
Unless anybody has something burning, I'm gonna try to move us along a
Okay.
little bit because I think we are behind.
well,
I think
thank you so much. Sue knows how to get a hold of me.
Megan, thanks a lot.
They all know how to get a hold of me. I know you guys all know how to get a hold of Lauren McCarthy. Thanks for the time. Feel free, if you think of questions later, to reach out to us.
All right, LDHA updates, Kathy, Marie.
Yeah, let's see, what's on that? Just briefly, the LBJ has experienced some budget cuts to some of their funding. Some of it's minimal, some of it's significant, as you saw the sewer money, being one of them. And, as we know, the state's budget's not finalized yet, so there is the potential to have further cuts. So we are anxiously awaiting that to get approved, so we actually know what we are working with for FY26.
We also know, like Kathy stated about, when I know about, 27 to 28, basically we know that there's probably even more reductions come 27, 28, 29 up through 2030.
Any questions about funding?
Veronica, you're up next with, Nova Crisis.
I'll just very briefly just give you guys an update. We are local vendor affiliated Sante, who has a contract for our local mobile crisis response in the community, has probably for the past 2 years been struggling significantly with staffing and retention. Really, as a result of the pandemic, social workers kind of going to providing private practice, being able to stay home. It's been very difficult to get social workers back into the field. And so as a result, our team has really not been able to provide the 2 full shifts of mobile crisis in our community over the last probably 18 to 24 months. They do continue to provide the full call center and have been able to, as we see with data across the state, they are able to manage quite a bit with just a call center, but the response that we're really looking for has been, they've had a little bit more challenge. But we're really excited to say that February, most of February and most of the month of March, we are back to being able to offer 2 full shifts, minimally Monday through Friday. The Central Maryland Regional Crisis Team is also accessible, and they have hours Monday through Thursday from 9 until midnight. Monday through Friday, 9 until midnight, and the weekends from midnight until from 12 p.m. until midnight. So they do have an overlapping shift between 1 and 9. So we can continue to utilize the regional team to support the mobile crisis team, but we're excited that they have been able to begin the process that they've tried to be very creative in how they're advertising and how they're hiring, trying to do some different approaches, hiring some part-time folks in order to really meet the needs of the community. So we're moving in the right direction. I can say that we did see a dip in what they were able to provide over the last couple of fiscal years, but they are continuing to open cases, and so far in the first 2 quarters of this year have opened 273 total cases. So they're going out, responding, meeting with folks, providing crisis mitigation, follow-up, ensuring that people get referred to community providers or reconnected with community providers. So I'm excited to see what the second half of this fiscal year will look like with them being more staffed. Yeah.
Do you often deal with juveniles?
Our mobile crisis team is a lifespan team, so they will work with all ages. And yes, they do deal with young people. That's all I have. Kathy?
It's me again, sorry. I didn't organize the agenda very well, did I? Annual plan, we have an extension on our annual plan that's not due till April now, but I believe we have a final draft that will be sent out to the OPPG for you all to review before we actually send it to BHA for approval. So that you can look for that in your mail soon. And Marie, myself, and Amy will be attending. I think most of you have heard about assisted outpatient treatment, the bill that was approved last year. right, last year, for individuals suffering from mental illness to possibly be court ordered to treatment based on certain criteria. So there is a summit in Annapolis at the end of this month, and the three of us will be attending that. So it'll be statewide, people from the state, across the state that are involved in assisted outpatient treatment. Interest from all levels. It'll be judiciary, lawyers, public defenders, down to clinical staff, those kinds of things. So
Would this have anything to do with like what goes on at the hospital?
no,
Because when I've had to take my grandson twice for actually I think it's 3 times for we got court ordered emergency petition. And even though we gave all kinds of information to the staff there, the psych people let him go with no discharge plan or anything. And this kid was not just using drugs, but into all kinds of illegal behaviors. And I mean, his mother and I, and his father and his other grandparents, I mean, we were all, and I have a PhD in the mental health of teenagers with autism or intellectual disabilities. And so I went with his mother to get these petitions from the court, and I would talk with the mental health staff there at the hospital. And I'll be honest, they are totally incompetent. And all they did was embolden this kid because he knew he was getting off. You know what I'm saying? And so that's why, in fact, I've even talked to our state legislators about changing some of the stuff for juveniles, because it's really, and it's not just my grandson. I mean, I've talked to the guys that are working the juvenile services department, and they are so beside themselves over all, not just what happens at the hospital, but just the mental health problems, and then how the kids get off from everything, and then that just emboldens them to do more. So I don't know.
This bill will affect anybody who's over the age of 18, not anybody under the age of 18. So families would be able to petition the court to ask for a court order to be put in place that they have to attend treatment. The unfortunate thing is the way the bill's written right now, there's no judiciary bite in it per se, because it doesn't allow the court to impose any other processes other than to just say they're court ordered to treatment. So, and then with that treatment comes along a team of people, a psychiatrist, a caseworker, and a peer to work beside them to get them engaged in treatment, stay in treatment. So unfortunately, there isn't something right now for juveniles.
Well, why do you think, I mean, do you have an idea maybe why that is? Why there is no kind of further to help juveniles get treatment or mental health treatment or whatever?
Yeah, I can't answer that. I think it's a question for our delegation. Unfortunately, we're still in the midst of putting in bills and those kinds of things.
Yeah.
So I think you should talk to the delegation here.
Yeah.
And Carol about your concerns.
Yeah, I've talked to a couple of them about it already. Yeah, because it's just, it's a mess. And I know that we're not the only family going through this stuff.
And unfortunately,
AOT is very specific to certain criminal charges and a certain period of time. I believe it's within the last 36 months.
Yeah.
And the criminal charges are a greater magnitude than like simple trespassing or things that we're in Carroll County. I think the assessment that the state did of all of the people over the last 3 years was we would have 10 people each year that were eligible for this program. We talked about this a little bit at the last quarterly meeting, that we had been meeting with stakeholders in this process because we were very unclear on if there was any funding availability at all to go with this program. And unfortunately, not one county in the state voluntarily said they would stand up an assisted outpatient treatment. So it's back on the state, the Behavioral Health Administration, to stand that up. In the end, we felt, and all of the partners that we spoke with felt, that there was not enough information for us to make an educated decision about what we were getting into. And if we were to decide yes, we could not change our mind after January 31st. And if we said no, we can't change our mind. So at that point in time, we had to opt to say no because they were building the plane while they were flying it. And they couldn't give us, I mean, we had plenty, like 3 or 4 slide presentations. And basically they sat and read to us off of the slides, and it would write down all of our questions. And then we would get an FAQ, which had some of the answers to the questions they were able to answer at that time. And, you know, we can't unknowingly go into something that may cost us $500,000 a year and not know where that money's coming from.
And the state has no long-term sustainability for any of it, so.
Yeah.
So we'll see. Yeah.
It was a big giant question mark.
So we may be able to present more when we come back, in the next June meeting.
Yeah, it'd
Quarterly
be interesting to
meeting.
hear what they
Yeah.
say.
We are too.
We'll keep you posted. We are too.
It's Sharon. I just.
Oh, sorry.
Hi, I'm not sure who in the room was speaking, but I just want to encourage you, if you have concerns about the emergency department, you can call the hospital and reach out to the patient advocate, or you can email me your concern directly and I'll make sure it gets forwarded to the right person.
Oh, believe me, honey, I talked in person I talked to the president of the hospital and everything about this, and nothing was done. No changes whatsoever.
I don't know if he was feeling what, Brooke or.
Who's presenting, Amy?
So we are splitting it up.
Okay.
Amy, would you like to go first?
Sure. I'll just give a brief update on the abatement grant. So Carroll County Health Department was awarded $454,000. Thank you so much. From the Maryland's Office of Overdose Response. And we were awarded that to evaluate the ability of systems at different intercept points across the lifespan to recognize impacts of prenatal substance use, specifically prenatal opioid use, and to identify children who have been impacted and refer to appropriate support across all domains, family, individual, and in some cases provide targeted training to strengthen specific systems. So the overall goals of the project are to decrease the incidence of prenatal opioid use, but also to mitigate the long-term impacts that can come from prenatal opioid use. This is a 2-year project. Year 1 is going to include essentially comprehensive data collection, a needs assessment initiative that includes survey focus group, key informant interviews, a resource mapping project, and year 1 will culminate with a 3-day summit. Year 2 will be spent using the data that we gained and the information we gained from year 1 to engage in some strategic planning with our partners, targeted workforce training, and developing a health communication media campaign. So just 2 other quick updates. First quarter progress. This grant does run January 1 of 2025 to December 31st. And then again, that time frame the next year. So it's not a typical fiscal year. So quarter 1, we're in the process of hiring a full-time position to support this project. And we're very, very close to a contract with the University of Maryland to provide us both with technical support around the data development tools and the development of data collection tools and also analysis, but also the prevention expertise. So they really have that unique blend of experience that we need. Next quarter, we'll focus on convening an advisory group of partners that will help us guide this project and oversee the development of those data collection tools and secure IRB approval. And we'll also work with the University of Maryland to ensure that consumers, persons who have been exposed prenatally to opioids, and parents or caregivers of persons who have been exposed prenatally have the opportunity to be involved from the beginning with survey design, with that process. We'll also be making sure that the survey is available in English and Spanish, and that focus groups and key informant interviews have ASL interpreters present, and that there is an option to take the survey by phone to ensure that we're able to get that representation of individuals with varying literacy abilities. So we'll be able to update you more on that as the project continues.
I got a question. Amy, can you hear me?
Yes, I can.
I was just reading the, I guess the thing the governor sent out yesterday, or maybe you guys sent it out, about the restitution fund and the discretionary awards. And I'm just trying to figure out in here, it was very informative, but talks about 15% of the proceeds that Maryland's going to receive from the opioid-related legal settlements are designated for use through the competitive funding opportunities. And I know that some areas like Baltimore City did their own lawsuit and they just got like 600 and some million. In the big picture, I mean, Maryland got $31 million for the state discretionary abatement fund. How much of that goes directly to the counties? How much of it has to be going through the grant process? And maybe sooner, I thought that our county had gotten together with other counties to do a separate lawsuit as well. I'm not sure about that. Just explain at a high level how this is all going to play out with this.
I think
this
Avery can answer your question.
Avery will take that.
Yeah, it's a complicated answer, so happy that I'm here to help with it. So in short, there are multiple lawsuits, which is what really complicates this. The biggest lawsuit and the one that is purview to the national settlement is the Janssen and Janssen settlement. And that one is broken down in, oh my goodness, let me recall the numbers. Hold on, we have a little tab on our website that I'm going to pull up for my reference. But so the majority of that money actually does go to locals. In two different pots of money. So there are direct payments that go to local governments, and then there's the targeted abatement fund, which is what Amy was just speaking about. And the targeted abatement fund basically requires that a plan be submitted for us to review. And then those funds are given to the locals. So we're really just kind of like a middleman in the process. And then that other money just goes directly to the local governments. And again, that's through the county commissioners. Folks sometimes think this goes to the local health department. We're like always hopeful that the OPTs and local health departments are working with the county commissioners. But if you're not sure why that money is not moving, that is the person that I would speak to. And then as far as the state breakdowns go, so there is the state discretionary abatement fund is 15% of the funding. And that is what is required to be released through grant opportunities. So that NOFA, or that, I'm sorry, award release from Monday is from that state discretionary abatement fund. And then there is additionally a state allocation, and that is used at the discretion of the state. So that means we could make it available via grant opportunities, or we could use it for state programs related to substance use funding. So in total, that's 30% that the state has, 15% of that's required to be available through grants. And then there is a total of do math really quick. There is 70% that's going to locals. So 45% is that targeted abatement fund. And then 25% of that is a direct payment to local subdivisions. And we have a breakdown on our website that kind of walks through all of what I just said, because it's a lot of words and numbers, and I will drop the link for that in the chat. But you can also see it if you go to our ORF Advisory Council tab. There's a little tab underneath that says Settlement Overview that has a lot of this information.
Okay, and what you sent out was informative. I guess it came out yesterday, the day before. But so the direct stuff to the jurisdictions has already happened to the locals? Is that
correct? Yeah. So it happens on a bit of a rolling basis. That's the other complicated part with this process, because there's multiple settlements. It kind of varies when payments go out. But yes, those direct payments should be rolling right now. And if they are not, we can help track it down. There's also a really helpful resource that I will also drop in the chat that allows you to click the settlement type. So like I said, there's multiple lawsuits, so you can click based on lawsuit, and then you can click the state, and then there's an option to select by your jurisdiction as well. And you can see what that total direct payment would be. And then if they're not processing, our grants folks have contacts that they can get some additional information for you guys as well.
And these are not just one-time settlements, right? This is ongoing for a number of years? Correct.
Yes, so it depends on the settlement. Janssen and Janssen, that one is over 18 years, but some of these only pay out over 2 years or 5 years. So it honestly, it makes it quite complicated for folks to plan around the funding, which we really understand. And so our office is always open to having conversations, but yes, so the biggest settlement is over 18 years, but there are some other smaller settlements that are also, paying out that do not pay over as long and are in shorter time frames.
Yeah, good. Thank you.
Yes, of course.
Sorry.
Yes, Susan, our office and the grants office have a team that monitors the funding, and we also submitted our opioid abatement plan on behalf of the county and this group, because the funding that was there with the MAT services in the jails, it's really basically covering the services. So, and that's what we did with the state funding.
Yes. No, I was just trying to figure out the number of dollars and how much, I mean, I saw that we applied for this one, which is good for the prenatal, but you know, if that opportunity is going to keep coming up and how we decide which things we're applying for. Because I know Palm City got $600 and some million. It's a lot of money. You know, make sure it's ongoing. You know, what are we doing with it, especially for this issue?
And I lost track of it at the point where we did file a separate lawsuit with other counties. And there was some communications about you had to be a county of 500,000 or more to get the direct funding, and then the rest of the funding was coming from the state through to the counties, to the jurisdictions, and the formula that was used. But we did in this meeting, and I think I attended the open session with the commissioners where we stated what the opinions of the group were for the use of the money.
So we'll get ongoing money, plus we can apply for these grants for special things.
And we have a very rough projection, like Avery spoke to it. It is difficult to say in 5 years, we're gonna have this much money. Just because of the settlements are, like she said, there's 6 or 7 of them. And then there's also the Purdue settlement, which hasn't even happened yet. So we have a projection out through, I think, 2038 of how much money we expect to have through this process. But it's been, I wouldn't say that it's 100%. This is what it's going to be. It's our best projection based on the settlement. You can, if you search and drill down, you can find very specific information for each settlement through the national portal, but it's not easy and it's very time consuming. And again, it's just a projection.
And I think each settlement has different.
They have different timeframes. There's a couple
Not
settlements.
just timeframes, but very specific things they can be used for or not be used for.
Correct. And the amounts change. Like some of the settlements are front loaded, so you get a bunch of money up front and then it really trails off. Some of them are one time, so the money comes one time. Some of the settlements are as small as $5,000 to Carroll County. So it's, we're doing our best to sort of project what we'll have. And that's why we were a little bit cautious in undertaking a lot of initiatives until we really felt like we knew what was coming. And really MAT in the jail, which was not projected to be funded through the county, this is a perfect fit. So we're using the majority of our funding to support the actual MAT operations inside the jail. And then when Megan was talking about the peer and the counselor bringing people from the jail to the treatment, that's another funding source that we're funding that as well through the county. So yeah, it seemed like it was going to be this big windfall of money and it really hasn't. I mean, it is a significant amount of money, but it's just stretched out over a long period of time and it ebbs and flows. So
well, and when the state put into place the unfunded mandate of MAT in the detention center, it didn't really help us with the abatement money, right? Because the sheriff needs that money to be able to run that program, and it was clearly understood that moving forward and if that's funded, this will be continued.
And it is a very expensive program.
Yeah.
MAT in the jail is very, very expensive.
Right.
I will very quickly go through. I just wanted to provide some updates about some of the suicide prevention initiatives that are taking place in Carroll County. So just so everyone is aware, if you haven't heard already, but we have here at the Health Department a partnership with Carroll Community College for adult as well as youth mental health first aid classes. These are evidence-based trainings to learn how to respond to a mental health challenge or crisis. We also now have Question, Persuade, Refer, which is called QPR. And this is a suicide prevention training, which teaches how to recognize the warning signs of a suicide crisis and how to offer support. Of course, we have ongoing 988 advertising countywide. Recently, we've had a specific Tawnytown targeted 988 boost. And we're also funding 988 billboards in Tawnytown, Westminster, Hampstead, and Sykesville. We have the Maryland Department of Health's Firearms Safe Storage and Youth Suicide Prevention Guide, which we are starting to try to get out to the community via various community events and health fairs. We have recently signed an MOU for an initiative called Lock and Talk. This is through Virginia's Harvard Planned Research Informed initiative, which encourages community conversations about mental wellness and lethal means. Their logo is Lock Meds, Lock Guns, and Talk Safety. So the next steps are completing a comprehensive training, which a few of us have scheduled at the end of the month. We continue to have our Suicide Prevention Coalition. We're currently reviewing 10 years of data, and we're engaged in a strategic planning process to identify local contributing factors for suicide. We have our epidemiologist who is doing a literature review to determine which are indicated as risk factors and provide research-based initiative options that the coalition will then review and decide which steps we want to take moving forward.
And I have to say thank you to the sheriff's office because he let us dig into his data. And our epidemiologist was able to go over there and dig through it so that we could have some really great information about the last 10 years and what's happened.
And then also in addition to our coalition, there are other initiatives happening in the community, such as a meeting with community partners, including Carroll Hospital Center, which provide families with resources for children who were suicidal and discharged from the hospital. We're working with a representative from the American Legion who is leading a specific veteran suicide coalition in the county as well. And they have some specific veteran initiatives that they're working around. We offer the sources of strength support through the Carroll County Public Schools through using funding from MDH grant to support CCPS evidence-based suicide prevention program, Sources of Strength. This funding enhances and expands adult advisors and peer leader activities and supports leadership days for peer leaders. And then we also have the Columbia Suicide Severity Rating Scale, which is part of our V-Power strategic plan within our Bureau of Prevention, Wellness, and Recovery. This is an evidence-based tool to be used by community members to screen for suicidal ideation and provide next steps. We've trained over 300 people at our Risky Business Conference and over 100 crisis intervention team officers. We are asking of you to continue to promote 988 within the community, and also either take yourself or encourage others to take our gatekeeper training, such as QPR, as well as mental health first aid classes. And then just very quickly, we are working on our OPT, our overdose strategic plan for Maryland's Office of Overdose Response. So in the next coming weeks to next few months, we'll probably be sending out emails asking for some answers to a few questions and gating some information to complete that. And that is all I have.
So Avery, there'll be a new plan coming from Carroll County eventually.
Amazing. Love to hear it.
All right, I'm gonna go ahead and I'm not gonna continue this part of the meeting. I'm gonna ask to close the overdose prevention policy group. So if somebody can give me a motion. I know we went over with the other part of the meeting, but I think it was important to have that presentation and that discussion.
I motion to close the opioid prevention policy group.
Second.
Second.
So moved, and we will, I have a motion to open the behavioral health advisory portion of the meeting.
I'll make a motion.
Thank you. Second.
Second.
Thank you.
Welcome to the second part of the meeting.
Unless anybody online wants to second or.
All right, we'll start off with the ASO Carolyn changes. Marie.
Yes, so as of January, we got a new ASO, which is Administrative Services Organization for Medicaid and Medicare dollars. So they actually were very proactive in trying to get ready for January 1st by implementing a lot of things before the new year. However, even with all of that pre-planning and scheduling of meetings and open sessions to talk about the benefits of Carolyn and all the things that we're going to be doing for us to make our lives easier, we still have had some bumps in the road since they have begun being our ASO and approving claims. We've had some providers still not getting paid. There was a glitch in the system that LVHAs have just recently been able to get in to try to do authorizations and approve them. So there have been a lot of authorizations that have not been approved, namely uninsured scans. There's been some glitches as to them giving us access to approve certain services that we don't approve. at our level, such as PRP and supported employment. That now goes to another individual within the state to do all of those. So we are working through the kinks. We're trying to make sure our providers are going to get paid. So there's been some bumps in the road and some warning curves. But we're hoping to get ahead of that as we move into the continuation of the year. Caroline has a very active website. So if you want to go to their website, you can and see all their provider alerts. Anybody can sign up to get these provider alerts. Please do. We recommend you do because things come out daily, if not sometimes more than once a day, as to changes being made as far as what would be allowed for authorizations, things that are being put on hold, things that need different coding. So just make sure if you are somebody who does billing or is involved in the process for applying for any sort of licensure or services, I would make sure you get a hold of that website and get yourself involved.
The state has 2 holds right now on levels of care, correct?
I know I just read that they're holding MDR funding for recovery houses right now, and they're holding anybody applying to become an MDR certified recovery house. So I don't know, Susan, you would know better. They're still holding up the licenses for, is it 3.1s?
It's PHP, TRP, IOP.
Right.
Okay. I know there's been some stuff in the paper about the slow process of approving licensures. That's at the BHA level, but we're hoping that they have streamlined a new online process, which will hopefully make things much easier and get people licensed quickly.
Do we just want to say what the acronyms are, just in case people don't?
Didn't it say administrative services?
No, for PHP.
Oh, I'm sorry.
I'm sorry. Partial hospitalization and psychiatric rehab.
Those are all like mental health side.
Yes.
Those are mental health.
It's all on that.
Oh, SUDs. Part of this is they're assessing the money that was overspent in Medicaid on those levels of care. And when you continue to let providers into the system, all you're going to do is have people billing for that level of care. So they have to come up with a way that they're going to determine how many of these beds are needed and how to judiciously give them out throughout the state so that every county gets what they need. It's every time I see one of those emails come through that they're holding a level of care, I'm like, because there are some levels of care we have more of in this county than others. And that's, a problem. And I think that's part of what they need to start to address.
So a question about that. So the hold on the recovery house, of course, I'm interested in this.
Yes, I wasn't even thinking about you there, Stephanie.
So
I will forward you that provider alert.
We sent it out from provider council, so you should have gotten, the provider alert.
Right, so I mean, and so we've talked about, but we're talking about funding that, like the type of funding that we're talking about for the women and children's.
No,
purchase.
different funding.
Different funding, okay.
This is for us to be able to help people moving into a certified recovery house,
Right,
but you're getting specific federal SOAR money
okay.
for that.
Right,
for that.
but you are looking to become MDR certified.
Yes.
Yes.
So that's gonna
Yeah.
be.
And they, for the future. Yeah.
Right, okay. Just checking.
Yeah, you're good.
Thank you.
We would let you know otherwise.
All right, thank you very much. Veronica, crisis services update.
I'm just gonna try to really breeze through quickly, just sharing an update about our sequential intercept model board meeting. For those who recall, last March, we hosted a sequential intercept model mapping workshop. We invited nearly 60 community providers across what is called the sequential intercept model. It is broken down into 5 different levels, and those levels really look at where individuals with behavioral health issues, either substance related or mental health, where they interact with the criminal justice system. And so what we sought to do last March was to explore not only what those areas, what resources we had in those areas, what providers we had that could connect people, and what gaps we might have had as well. As a result of that workshop, we received from the Governor's Office of Crime Prevention and Policy a sequential intercept model workshop kind of report. It laid out everything we did, everything we discussed. It's accessible on the dashboard through the Governor's Office of Crime Prevention and Policy. They have a sequential intercept model mapping dashboard, and you can go online. You can see across the state who's been mapped, what those plans look like, and Carroll County's is up there. The group during that meeting identified 3 priorities and then probably about 10 total priorities that we wanted to really be looking at to close the gaps in our continuum. And so we met as a group to discuss, we've got this great plan, we've got this, information, it's really noted it's going to hold our feet to the fire, but we would like to consider how do we move some of these initiatives forward. And so that team met on the 18th of this past month. We looked at our plan again. We again discussed some of the larger priorities that we've identified. We also discussed maybe looking at some of the lower level priorities because those might help move us closer to the larger priorities. And so where we have landed is that we're likely going to be working in some naturally created subcommittees. One, to look at and explore establishing a mental health court here in Carroll County. The other will look at how do we expand our services for nights and weekends? How do we expand really towards the ultimate? I know Kathy's legacy project has been for some time is a walk-in crisis center, if that's feasible. And so several of the team members are kind of looking at some of those options. We are planning again to meet in May. We're going to meet on a quarterly basis. We'll meet again in May and we'll talk a little bit more about how we're going to move some of those pieces forward. Some of the subcommittees, those who kind of naturally paired up, Judge Hecker, Judge Lewis, Laura Kozlowski from the Office of Public Defender. We're likely going to be inviting someone from the State's Attorney's Office. They're really kind of doing some of those conversations now, looking at the Office of Problem Solving Court, reviewing some documentation. So they'll give us a little bit more information when we meet again in the quarter. Then I'll be reaching out to the chief who is kind of spearheading the crisis walk-in piece. So I'll keep you guys updated on that. You are welcome to join. I will, of course, once we have the date, I'll give that date to Teresa so she can share that out to this group. And anybody who's interested in being a part of those conversations, you are welcome to join our board meeting. Again, we are hoping to meet quarterly and just really look at how we close the gaps, especially for individuals with behavioral health issues that continue to engage with the criminal legal system. That's it.
Amy on special populations.
So Amy Baker, from here at the Health Department, I'm the Program Director for Special Populations. And again, just for time, a couple updates. One is, I'm going to condense this with the overdose response numbers too, and do harm reduction. So I oversee our harm reduction program. One of the things that we do with harm reduction is we naloxone out into the community. So far, and we have 3 staff in that program, so that's just one of the things that we do. So far, we've had in this fiscal year from July 1, we've had 153 people trained and 10,630 doses of naloxone given out, which is a pretty good amount. We have 18 of those purple cabinets out and about in the community so people can access and get naloxone as they need it, as they want it. They can ask for training, but they don't need to be trained. But we've also done 18 training events. So we're going to train anybody who wants to be trained. It's a brief training, and everybody should have naloxone. So if you need it or know somebody who does, send it over here. They can pick it up. They can go to any one of the libraries. The detention center has it. The courthouse has it. The county office building, DSS, yeah, so 18 different. I have a flyer. That's one of the things we're doing in harm reduction. The other thing is one of our staff, our liaison, does a 5-week curriculum that she provides in lots of the inpatient settings for people who are either in early recovery or still in active substance use. And it's a really great interactive curriculum that's research-based and evidence-based. And she can do that anywhere, inpatient, outpatient. She does it at the rescue mission. Everybody loves it. So I highly encourage people, if you're interested or you have groups, it can be facilitated at pretty much anywhere. She also does it on her own in Carroll County and at the, she's done it at our local homeless shelter as well. I want to remind people, we do have peer support staff who are available. So if you need to refer somebody from the community, from your department, from your agency, a family member, this peer support is for 18 and up, and it is our peer support staff for people with lived experience who are in recovery for mental health and or substance use disorders. So they're here on site, but we do have peers embedded elsewhere in the community. And we're always taking referrals, so we can put that in the minutes and how you can get in touch with our peer supervisor, Jermaine. I do want to remind people too about our outreach and case management for people experiencing homelessness who also have major mental health disorder. So we have a case manager and another peer support specialist who go out in the community every single day and look for people who may be experiencing homelessness, who maybe won't come into any of our agencies. We have an enormous continuum of care here in Carroll County. Selena oversees the Circle of Caring Homelessness board, and then under that board we have a million subcommittees that all of us see each other every day, I think.
I think you get the word for sitting on the
But homelessness is still very much here and alive in Carroll County, and so we want to make sure that nobody falls through the gaps. The people we can't serve because of our funding, so it has to be people with major mental health disorder, HSP can serve, Human Services Program. They also have case managers, Citizen Services has homelessness services through the House of Stability program. So we really try to wrap around in it. I want to just emphasize that there is a need. We just did the point in time counts. Lots and lots of people went out in the community, including some of the commissioners, really got to see firsthand what homelessness looks like in our county. So Mike and Ricky are our PATH. That acronym doesn't matter. They're outreach and case management for people experiencing homelessness. And all you have to do is call, email, whatever. People can reach out to me or Mike, and we'll put that information or Ricky or put that information in there.
What was the whole time count this year?
When was it?
What was it?
Oh, what was
The
it?
number.
Oh, I'm sorry. Do you have that, Selena?
Let me pull it up.
Okay.
Keep talking about.
Okay, yes. We also developed under the Circle of Caring Homelessness Board a lived expertise advisory council. So we do have people with lived experience coming and advising us on how to make these services better, lower barrier, more accessible. The whole idea is to make homelessness rare and brief. So we work very hard as a continuum of care on doing just that, looking at housing that's affordable and available. And how to help people get into housing and maintain their housing. So a lot going on there. There's so much more I could talk about under harm reduction and peer support, but I do want to emphasize one of the things that Brooke said. In prevention and in my unit, we work in tandem to get the message out about 988. So I want people to be aware, and to that end, we do have giveaways for you guys. So don't leave without your goodie bag of 988 materials today. Just so you can give them out wherever you go. Doesn't matter in your area of practice or if you're out in the community, or if you just come across somebody and you think, oh my gosh, 988 might be really beneficial. Whatever kind of distress somebody's in, mental health, substance use, family crisis, whatever it is, suicidal crisis, 988 can help link people to our community resources. So.
And so the point in time count this year, in 2025, we did, it was in January on the 24th, and we did an unsheltered count and a sheltered count, which was people that were in any of our shelters. The unsheltered count, which we found on the street, individuals living in homelessness, was 18. And then our sheltered count was 135. In 2024, we didn't do a count. We were only required by HUD to do them every other year. But in 2023, our sheltered count in comparison was 99. And our unsheltered count was 23 for a total of 122. This year, our total was 154. I will say we had more people unsheltered in 2023. I would speculate some of that was because it was a much warmer day in 2023. Remember when we went out in 2025, it was very cold. We had that cold snap during the time we did the pit count. We were not even wearing jackets, some of us for the 2023 count, it was that warm. So I think that had some of an impact, but we definitely have an uptick in the numbers of homeless individuals here.
So when you say sheltered, I mean, you're doing it in January, so it's cold. So if you did it in June, would you come up with the same numbers or those people?
I would say we have more unsheltered in June, just because people.
Do you have the same numbers, it's just some are more unsheltered?
Yeah. We and speculate that maybe they do it in June, so it's an unrealistically low count for unsheltered, because the whole nation does it at the same time.
And it's one day, to us, because we know the numbers we're serving the whole year through with coordinated entry, shelter services, outreach. We know that number is very low in relation to what the number of individuals in homelessness are in our county. So, so the people we serve over a year's time are much higher than.
And are most of these people in our shelter, each of these shelters?
Within the night by night, the adult only shelter and then the family shelter, that's the count between those three shelters.
And they're open all year round?
They are.
And you have the homeless veterans,
Yes.
Yes.
are they aware of different, because I know, in fact, I'm one of the contributors monthly to Tunnel to Towers.
I don't know what that is.
Tunnel to Towers is an organization, in fact, if you look it up, TUT.org, they provide mortgage-free homes to Gold Star families with young children and first responders, families who's died in the line of duty with young children. They also provide homes, specifically homes for catastrophically injured veterans that are mortgage-free.
That's amazing.
And they are also in the process of eliminating veteran homelessness. So if you get in touch with them, they could, and it's only if you do, I'm a big proponent of this, like you tell. And it's only $11 a month that they ask people to donate.
Okay.
And, and they also have an online, shop where you can get, in fact, everybody at Christmas time gets gifts from Tunnel to Towers now from me, but, one of the things they're doing is they're buying up old hotels and renovating them. And that's how they're providing homes now. And I'll tell you what they do is, and then they also provide services for the veterans as well. And for the older veterans, they have a small home built for them, so that they actually get to have a
We would
separate.
love tiny houses here. One of the things I did mention under the Circle of Caring Homelessness continuum is our Veterans Ending Homelessness Committee, which is run by the Bureau of Aging and Disabilities. They do get a grant every year to end veteran homelessness. We've done an immense job. We go through a by name list every month, so we know who's on the list, who's been housed, who's pending for a voucher. We do have 15, I think, vouchers for veterans.
Vouchers, right?
Have vouchers here in the county, and then they link them with other resources for housing.
Well, and
as well.
that's
Yeah,
because
so we
a
use
lot
those
of times
resources.
the homelessness is still dealing with issues from when they were in combat and stuff, and whatever injuries they might have.
And so that's where a housing choice voucher, that's a HUD VASH voucher, is what they're called for veterans. That's where it's different than a regular housing choice voucher, because the VASH vouchers have case management services provided by VA case managers that follow them for at least 6 months once they're housed. So that's the difference between a regular housing choice voucher and then one that's provided through the VA.
Yeah.
It's an awesome collaboration. with
Well,
them.
I'll tell you what, Tunnel to Towers is just, I mean, and it was started by the brother of one of the firemen that died on 9/11.
Oh, okay.
His brother, the fireman, ran through the tunnels to get to the towers that
I
day.
see. Okay. That
Yeah.
makes sense. That makes sense.
Yeah, when you go online to the site, you'll see, and it's really, and they're very proud of the fact that 95 cents out of every dollar goes towards the veteran services.
I would be proud of
And,
that too. That's
yeah, I
amazing.
mean, it's really,
And
yeah, Frank Stiller is.
Our Veterans Advisory Council.
Absolutely.
Yeah, if you watch Fox News, they have commercials
All
for
over Fox
26
News.
hours all the time. Yeah.
Gotcha. Okay. Did anybody have any questions? Thank you so much.
Yes, thank you. All right, Veronica, did you have anything to add?
Nope, I was gonna let her go.
All right, perfect. All right, so before we close our meeting, I want to open up, we just have a couple minutes left. I know this is a time for announcements or anything that we did not get to. I just want to make sure you saw, I don't know if Tim left some of these flyers. Did he leave them over there? Okay, great. That the annual drug overdose and prevention vigil coming up on Thursday, May 22nd. So go ahead and mark your calendars. That's a very important event for our community. So please grab a flyer, or I'm sure we'll send it out at the minutes as well, if we can. Happy.
I just want to add 2 more things. I have been adding to the abbreviations and definition list that's attached to the agenda. So I added 2 more additional topics this month, and that would have been, well, 3 actually, AOT, harm reduction, and triage beds, just to give a reference and some further explanation. And if there's anything else that we speak about or that you'd like further information about, please let me know. Send Sue and I an email if there's something you want presented about on the agenda, because the agenda is really created internally. And this is a group partnership here. So if there's something that's you'd like to present to the committee, or you want us to reach out and have somebody come present about, please email the 2 of us and let us know. So thank you. That's it.
Very helpful.
Yeah.
I get mixed up like what you're doing.
I know. That's why I always think about you when I start thinking about what do I need to add to this.
You
So,
change the names.
yeah,
It's very
there's a
helpful.
lot. We use a lot of acronyms and it's hard.
I just want to say Beth Schmidt put the Tunnel to Towers link in
Oh, that was
the
a
chat, so that, when Teresa transcribes the minutes.
Oh, good, good. Thank you.
Thank you, Beth.
Can I make one
Yes.
announcement? Just a reminder, it's been pushed out through a lot of the different groups, but we have our Footsteps for Future Generations, which is our grandparents serving as older relatives raising grandchildren's conference. It's on March 29th from 9 a.m. to 2 p.m. And it's at Westminster Senior Center. It's a Saturday. And it's free registration, but you do need to contact us to make sure we have an appropriate count for lunch and breakfast. But we're going to be doing a seminar examining social media, trends to red flags, legal discussions regarding children's rights, adoption, guardianship, and custody, and then also coping with the emotions of anger, guilt, and grief. So you just can call over to our main line at the Bureau of Aging, which is 410-386-3800, and ask for Denise Valentine. So, but it's always a great group. It's usually a smaller group than our regular caregiver conference, but it's a lot of great conversation for those grandparents or older adults that are raising folks. And a lot of them, because they have now found themselves raising their grandchildren as a result of their children overdosing or being incarcerated as a result of substance use issues. So it's a lot of emotion on those conferences. So.
Thank you so much, Sonia. Tammy, you have your hand raised.
Hi, thank you. Just want to share an announcement. It's a rather sad one, but I feel like I should make it, say it so it's out there. We can put it in the minutes. But the medical respite, many of you know that, has been canceled. Just want you all to know that officially, LifeBridge Health and Access Carol, who have been partnership to provide an amazing $5 million gift to the community, are going to take it elsewhere. You guys know I've been talking about this for many years. It's definitely not the same thing as the program that, the Mountain Manor folks have been talking about. It's very different, but nonetheless, we this community is very important to us, but we hope that other things will work out for the community with regard to the medically complex folks that we're serving. Many of which have substance use disorder, but then some don't. So one of the things, if anybody has any specific questions, they can certainly reach out to me. And again, this was for the sober respite and also for the medical respite part with the bed nights. Thank you.
Thanks, Tammy.
Thank you, Tammy. Any other announcements? All right, and I will entertain a motion to close the meeting. All right. thank you.
You're making the motion, Teresa?
Yes.
Okay,
Any seconds?
I'll second.
All right. Thank you very much. Thank you all for attending.
Thanks, folks. Thank you.
Thank you. Oh, I just got her.
Thank you, everyone.
Somebody told her.
Oh,
Yeah. It's very complicated.
Oh, yeah.